Hi there, my valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa, and I am a clinical pharmacist by training and by profession. And I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I humbly urge you to sit back and spare me part of your very precious time to share with you some precious tips which may prove useful in your line of duty. So welcome to part 59 of our pharmacotherapy MCQ series, which majors in pulmonology. Question number 1 reads, Mr. J.I.R., a 62-year-old male patient, presents to your chest clinic and requests for medication therapy management, including vaccination recommendation from your team. He has a past medical history of COPD and has been using tobacco for a while. He currently administers 2 inhalations of Spiriva Respimat once daily, and he clearly tells you he has no desire to quit smoking at this time. He has had an influenza vaccine in the past 1 year, and according to the records, he has received no other immunization. So my question to you is, which of the recommendations listed below would be the most appropriate for Mr. J.I.R. now? Would you propose he receives PPSV23 vaccine today and a PCV13 vaccine in 8 weeks time? Or would you recommend he receives a PPSV23 today and a PCV13 at this visit as well? Or would you recommend he should receive a PPSV23 vaccine due to the fact that his age is less than 65 years? Or would you recommend this patient should receive a PCV13 today and a PPSV23 vaccine in a year's time? I'll give you 10 seconds to choose the correct answer. So I would recommend he receives only the PPSV23 due to his age, which is less than 65. Remember, we are told he's a 62-year-old patient. Now, according to the CDC, people above or in the age bracket of 19 to 64 years with chronic medical conditions such as chronic obstructive pulmonary disease should receive 1 dose of a PPSV23 vaccine. The GOLD guidelines further support this recommendation by indicating, if I remember well, that patients below the age of 65 years with an FEV1 below 40% of the predicted value and or with comorbidities should receive the PPSV23 vaccine. Now, both pneumococcal vaccines, the PPSV23 and the PCV13, are recommended for this patient based on age and recommendations for COPD. Now, according to the CDC, when the patient is 65 years or older, both PCV13 and PPSV23 are recommended, and the PCV13 should be administered followed by the PPSV23 at least a year from the moment you administer the PCV13 vaccine. And immunocompromised patients aged 19 years or older may receive 1 dose of the PCV13 followed by 1 dose of the PPSV23 at least 8 weeks later. So that's a special population. Then another dose of PPSV23 at least 5 years later. So if that was not clear, I would advise you at a later time to rewind this video. Now, only 1 dose of PPSV23 is necessary for those receiving PPSV23 at 65 years of age or those who are older at the moment they are receiving this vaccine. So let's move to the next question, please. And it reads, Mrs. HKB, a 23-year-old female, presents to your chest clinic complaining of occasional difficulty in breathing, especially during rugby practices, and she admits to inability, in her words, to take a deep breath, which has persisted for, again in her own words, several years, but appears to be worsening of late. So she's concerned. She admits to coughing at night 2 to 3 times a week, but denies any recent infections. She has a past medical history significant for allergic rhinitis, which she manages with over-the-counter loratadine at a dose of 10 milligrams taken orally once a day. And your chest physician suspects this lady may have asthma, and he would like to confirm his diagnosis. So my question to you is, which of the options listed below would be the most definitive means of diagnosing asthma in the case of Mrs. HKB's case? Would it be spirometry, peak flow meter, chest x-ray, or is it true that her current symptoms provide enough evidence to diagnose a case of asthma? I'll give you 10 seconds to choose the correct answer. So I would settle for spirometry. According to the NHLBI guidelines, which I would recommend you read, spirometry is an essential objective measure to establish an asthma diagnosis. Now, a chest ray, on the other hand, can be valuable if needed to rule out possible diagnosis, but it isn't used for the direct diagnosis of asthma at all. Now, while her symptoms provide evidence towards the diagnosis of asthma and staging of the same, they aren't the most definitive approach to diagnosis, as the patient doesn't have these specific symptoms for diagnosis. So I would not settle for D. And B, the use of a peak flow meter or peak flow meters is beneficial for monitoring. It is not used as a diagnostic criterion at all during the diagnosis of asthma. So let's move to the next slide, please. And the question reads, Mrs. JRM, a 24-year-old female patient, presents to your chest clinic with an uncontrolled asthma despite being on medium to high dose inhaled corticosteroids, what we call ICS. She's also on a long-acting beta-2 agonist, a LABA, and a leukotriene modifier. After the chest physician further evaluates and further discusses with this patient, he decides to add theophylline to her current regimen. So my question to you is, which of the statements listed below concerning theophylline is wrong or untrue? Is it is a major substrate of CYP1A2, or is it the desired drug reference range is 5 to 15 micrograms per ml in the serum, Or is it true that it can increase the risks for cardiac arrhythmias in patients with cardiac disease? Or is it can increase the seizure threshold? I'll give you 10 seconds to choose the correct answer. So it is untrue that it can increase seizure thresholds. Now we know that theophylline can lower and not increase the seizure threshold, and thereby increase the patient's risks for developing seizure, especially at higher drug concentrations and in patients with known risks for seizures already. That is, those with convulsive disorders and so on and so forth. Now, theophylline is a major substrate of both CYP1A2, CYP2E1, and even CYP3A4. This is relevant in the context of drug-drug interactions. This drug poses a challenge when co-administered with many other drugs in polypharmacy, so you have to be cautious. Now, the common inhibitors of A1A2, just for your information, are amiodarone, cimetidine, ciprofloxacin, and fluvoxamine. While the one common inhibitor of 2E1 that I know of is disulfiram and Tabius. And then the examples of inhibitors of 3A4 enzyme system include amiodarone, erythromycin, the azoles, itraconazole, ketoconazole, and even protease inhibitors used in the management of HIV, and even verapamil inhibits the 3A4 enzyme system. That's just for your information. Let's move to the next question, please. So, Mr. JPO, a 69-year-old male patient, presents to your accident and emergency department with an acute chronic obstructive pulmonary disease exacerbation. Currently, his oxygen saturation is 85% on room air. The clinical team is establishing supplemental oxygen therapy. So my question to you is, which of the target ranges listed below would be the most ideal for Mr. JPO? Would it be 95 to 98? Would it be 98 to 100%? Would it be 88 to 92%? Or would you settle for any value greater than 85%? I'll give you 10 seconds to choose the correct answer. So 88 to 92% would be the ideal range. Now, supplemental oxygen is an essential component of chronic obstructive pulmonary disease management, especially during an exacerbation. Now, patients should be provided with supplemental oxygen to a target oxygen saturation of between 88% and 92%, because most patients with COPD usually live at lower oxygen saturations, and therefore giving them too much oxygen could reduce their respiratory drive, causing further retention of carbon dioxide, and this can lead to worsening of a case of respiratory acidosis. So don't give them too much. Now, there are numerous methods for non-invasive supplemental oxygen delivery, such as high-flow nasal cannula, non-rebreather mask, and the bi-level positive pressure ventilation. Now, patients who can't tolerate non-invasive ventilation, in their case, we may intervene by intubating. They may require endotracheal intubation for ventilatory support. So just take note of that. Now, while providers still use arterial blood gases, venous blood gas assessment of bicarbonate and pH can be used in patients who aren't in respiratory failure. Then I would just like to note that venous blood gases are significantly less painful to the patients than the arterial draws. So just pay attention to those when you have to closely monitor their saturation. Let's move to the next slide, please. And it reads, which of the statements listed below is or are accurate concerning chronic management of asthma? Is it true that omalizumab should be initiated early on as prevention of an allergy-induced bronchospasm? Or is it true that all patients in general should receive a rescue inhaler of salbutamol? Or is it true that hypertrophium bromide meter-dose inhaler should be initiated early on and used 4 times daily? Or is it true that long-acting beta agonist LABA should only be started after the initiation of an inhaled corticosteroid? I'll give you 10 seconds to choose the correct answer. So both answers B and D are correct. I would like to remind you that chronic asthma is managed in a stepwise manner depending on the degree of control of the disease. You individualize it depending on how well the patient is progressing. Now, all asthmatics should be given a rescue inhaler of salbutamol, which is a short-acting bronchodilator, for pro-renata use when there are acute exacerbations. Now, along with the use of pro-renata rescue inhaler, inhaled corticosteroids, what we abbreviate as the ICS, are the next most important treatment option. Now, once the patient is on an ICS, the number of other options exist out there that can be initiated in any other order specific to the patient's specific symptoms. For example, the leukotriene receptor antagonists, the low-dose theophylline, and even the long-acting beta agonists can be options as add-on therapy. Now, biologic agents such as omalizumab, which is marketed as Xolair, are typically add-on in patients who have already failed other standard treatments. So that knocks off alternative A. I would also like to remind you that ipratropium bromide is an inhaled short-acting muscarinic antagonist that is used mainly for COPD, but can also be used in acute management of asthma and not in chronic management. This patient, remember, has chronic asthma. Now, the mainstay of treatment for chronic asthma includes a rescue inhaler, I'm just underscoring, or a reliever inhaler containing a short-acting beta-2 agonist, a SABA, such as salbutamol, then inhaled corticosteroids, and then we may add on or choose not to a leukotriene receptor antagonist. We may also add on or not a LABA long-acting beta agonist, and we may also choose to add a low-dose theophylline as per guidelines. So all those are treatment options that we can use in difficult to control cases of asthma. Let's move to the next slide, please. And the question reads, your chest physician is initiating a patient on a fluticasone propionate dry powder inhaler, what we abbreviate as DPI, for asthma treatment or management. This patient has never used a DPI before. So my question to you is, which of the counseling points listed below would be appropriate for this type of inhaler, for a DPI to be specific? Is it actuate the dose by pressing down the canister while breathing fully? Or is it this inhaler is best used when used with a spacing device? Or is it shake the inhaler prior to each use, or is it forcefully inhale through the mouth to deliver the dose? I'll give you 10 seconds to choose the correct answer. So I would advise the patient to forcefully inhale through the mouth to deliver the dose. Now, DPIs typically rely on the force of the patient's inhalation in order to transport and even to break up the powder particles to disperse them into the lungs for effectiveness. Now, the other three counseling points, that is A, B, and C, apply to metered dose inhalers, not to dry powder inhalers. Now, the correct device technique is an important component of inhaler use, and I would like to remind you that poor inhaler technique has been linked to poor clinical outcomes. It is important to note the differences in inhaler techniques when you are addressing a patient face to face, and to communicate the same to them, making corrections along the way. Let's move to the next slide, please. And the question reads, which of the statements listed below is the most accurate regarding the use of methylprednisolone acetate for the management of asthma? Is it has the potential to cause subcutaneous atrophy at the site of drug administration, or is it is the active metabolite of prednisolone, or is it comes in prefilled oral dose pack for easier outpatient use, or is it can be administered by IV infusion for acute asthma exacerbations? I'll give you 10 seconds to choose the correct answer. So A is the correct answer. I'd like to remind you that methylprednisolone acetate, which is marketed as Depomedro, is a corticosteroid available as a suspension that is administered by two routes, intramuscularly or via intra-articular injection only. It's never administered IV, otherwise you'd occlude the blood vessels and complicate the patient's clinical outcomes. It can't and should never be administered IV due to its formulation, which is a suspension. Now, due to Depomedro's long activity, it can be given as a single dose for an acute asthma exacerbation, and it can replace the need for oral steroids. Now, the only formulation of methylprednisolone that can be administered IV is the methylprednisolone succinate, which is marketed as Solumedro. Note the difference. It's a clear solution. Now, prednisone is the prodrug of prednisolone, so it's misleading to say methylprednisolone is a prodrug of prednisolone. And I would like to emphasize that Medro dose packs are prepackaged forms of regular methylprednisolone, not prednisolone acetate or succinate, and it isn't associated with tissue atrophy. Let's move to the next slide, please. And the question reads, Master KMM, a 7-year-old boy, is initiated on Montelukast, which we market as singular, to be used along with his QVAR inhaler for asthma control. Now, while refilling his second month of Montelukast prescription, his father comments to the pharmacist that his son, in the father's own words, is having vivid dreams and acting aggressive. End of quote. So my question to you is, which of the statements listed below would be your most accurate response to this concerned father's concerns? Would you tell him, I will report those adverse events to the Food and Drug Authority, the FDA, and advise him to continue the medication as prescribed? Or would you tell the father, I will not fill Montelukast for you. Your son doesn't need to take it? Or would you tell the father, psychiatric adverse events can occur with Montelukast? I can contact your son's chest physician to discuss treatment options with him? Or would you tell this concerned father, vivid dreams and aggression aren't adverse events of Montelukast? Please continue his medication as prescribed. I'll give you 10 seconds to choose the correct answer. Would advise the father that psychiatric adverse events can occur with Montelukast and opt to contact the son's chest physician to discuss safer treatment options. Now, we know that Montelukast, which is marketed as Singular, is a leukotriene receptor antagonist which is administered once daily orally for chronic treatment of asthma, allergic rhinitis, and even exercise-induced bronchoconstriction. Now, while vivid dreams and aggression weren't identified as the most common adverse reactions in the pivotal trials for this particular product, psychiatric adverse events have been reported. Now, all potential drug-related adverse events should be reported to the FDA by contacting the drug manufacturer and as part of pharmacovigilance. And the best therapy for the patient should be discussed with the prescribing physician when you note that there are adverse drug events. Instead of torturing the patient to continue taking a drug they do not tolerate well. Let's move to the next question. And it reads, your chest physician is managing a patient with IPAH who belongs to the WHO Group 1 and is looking for a medication which can be orally administered and is readily accessible. The clinical team at your hospital is aware that some medications used to treat this condition have serious side effects associated with their use. All of the medications listed below have a risk evaluation and mitigation strategy, what we abbreviate as REMS, a term commonly used in the US. So they have an REMS program except one of them. So which drug is this exception? Is it macitentan, which is marketed as Opsumit? Is it riociguat, which is marketed as Adempas? Is it selexipag, which is marketed as Uptravi? Or is it bosentan, which is marketed as Tracleer? I'll give you 10 seconds to choose the correct answer. So C is the correct answer, selexipag, Uptravi. Now we know that macitentan, riociguat, and bosentan all have boxed warnings for embryo fetal toxicity, and they are available to females only through a risk evaluation mitigation strategy, what we call as an REMS program. Now, risk evaluation mitigation strategy is a strategy to manage a known or potentially serious risk associated with a drug or a biologic product. Now, a REMS will be required by the FDA to ensure the benefits of a drug or a biologic product outweigh the risks. Now, riociguat or Adempas is an oral soluble guanylate cyclase stimulator that is used for the treatment of pulmonary arterial hypertension. Macitentan or Opsumit and Bosentan, which is Tracleer, are also oral endothelial receptor antagonists for the treatment of pulmonary arterial hypertension, while Selexipag is an oral prostacyclin receptor agonist for the treatment of PAH. Now, just for your information, the WHO subdivides PAH into 5 categories, which I would advise you to read further on. We know that G3, for example, is most commonly hypoxia-associated pulmonary arterial hypertension, as seen in COPD and in interstitial lung disease, for example. So, and the G4, for example, is most commonly thromboembolic pulmonary arterial hypertension, as seen with pulmonary embolism, with tumors around the lung region, and in cases of foreign material around that region. And the group 5, for example, includes situations with unclear etiology. Now, group 1 involves those that are idiopathic. They may involve connective tissue disorders. It may occur in the HIV population, in patients with sickle cell disease, and so on and so forth. And group 2 encompasses mostly heart failure patients. They could be systolic heart failure or diastolic heart failure patients, or even those with valvular dysfunction. Just for your information. Let's move to the next question, please. And it reads, Mr. N.O.N., a 59-year-old male patient, presents to your chest clinic for assessment of whether he has chronic obstructive pulmonary disease or not. According to his medical record, he has been admitted twice within the past 12 months, within the past 1 year. A CAT assessment is done by your clinical team, which reveals a score below 10. So my question to you is, which of the treatment regimens listed below most closely aligns with the initial pharmacologic treatment based on Mr. N.O.N.'s treatment group? Is it a short-acting bronchodilator, a long-acting bronchodilator, a long-acting muscarinic antagonist, or a short-acting muscarinic antagonist? I'll give you 10 seconds to choose the correct answer. So, long-acting muscarinic antagonist would be the best bet in this particular case, because we know that Mr. N.O.N. is currently in group C due to a CAT that is below 10, and he's had more than one exacerbation leading to hospitalization. Now, according to the GOLD guidelines recommendations, that causes him to be classified class C. Now, initial therapy in group C should consist of a single long-acting bronchodilator. Now, this is based on data from 2 studies evaluating LAMA and LABA in a head-to-head fashion. Now, studies found that the LAMA was superior to the LABA at preventing exacerbations. Now, a long-acting or a short-acting bronchodilator is recommended for all Group A patients. Now, for patients in Group B, initial therapy should consist of long-acting bronchodilators. Now, for patients in Group C, they have special recommendations to receive long-acting bronchodilators with a LAMA. And for the patients in group D, for example, they may be initiated on the combination of LAMA and LABA without much ado, without many complications, and with good clinical outcomes. So, my highly esteemed viewers and listeners, that brings us to the end of this video. If this video benefited you in any way, I would like to kindly urge you to remember to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come. Thank you very much for viewing and for listening to me. I sincerely appreciate your partnership and your continued support and kind collaboration. I look forward to interacting with you in part 60 of our Pharmacotherapy MCQ series. Thank you.